Where is everyone?
So, Chris, I have a student working on a historical paper about the first use of radiation to treat AVMs.
I love it.
So in the 90s, this was like oft quoted, but like clearly no one had ever read, let alone or seen, let alone read the papers. Is it from a book by Wilhelm Magnus,
Yeah.
written in Norwegian? And then you remember seeing the reference in the 19 teens.
Yeah.
So I have a Norwegian colleague who I told about this, and she tracked it down and translated it. So we're gonna, write a historical vignette about it. But
That is great. That is great.
as someone who demonstrated the non-efficacy of RT for AVMs, I thought you'd find that interesting.
Well, and I wrote a single author paper as a resident on radiosurgery for AVMs, a review. And I went over and wanted to spend time. I wanted to see what it was about. I went to visit Gelberg over at the cyclotron in Boston, as part of Harvard. And he was very suspicious. What are you doing here? Why are you here? It was, he got pretty paranoid towards the end of his career. But he was an ingenious guy. And he kept a prospective database for one of the first people to keep a prospective database on computer. It was great.
And then Seppi, Hanjani, I remember, went back and refined the data.
She worked with me because we had access. His family gave us access to his data. His data was all in a two 18-wheelers that he had moved to California. So we had to get them back. It was like an archaeological dig. Yeah, Paul Chapman really did a lot of it. It was fun. It was a lot of fun.
But it was you wrote the paper that showed that the obliteration rate after radiation therapy is only 15%.
Right.
Yeah. So anyway.
That's interesting. I'll look forward to that.
Yeah. I think it's going to be interesting.
Dominic, where is everybody?
I'm not sure. I'll find out.
I think they're just finishing rounds, maybe.
Probably, but
See, when the cat's away, the mice will play.
That's right.
Yeah, I was at the second international radiosurgery meeting was in Boston when I was there, and I remember Seppi presenting it there.
I remember that was at where'd they have it? At one of the colleges. Yeah.
Yeah, Eben Alexander and Jay Leffler ran the meeting.
Right.
all right, I guess we'll get started.
Yeah, that'd be great.
Yep. So it is my pleasure as well as honor to introduce Mike Schulder as our grand round speaker. Mike and I have known each other for, I guess, 40 years or so. He was a junior resident in neurosurgery at Einstein when I was a medical student with an interest. And Mike was one of the handful of people like Bob Keating, who took me under their wing and ushered me into the field for good or bad. And so Mike is a graduate of Columbia's College of Physicians and Surgeons. He trained in neurosurgery at Einstein. He is an international luminary. He has been the president of the World Stereotactic World Society for Stereotactic and Functional Neurosurgery. I should get that right since I'm on the executive board. As well as having other titles. He is the vice chair and residency program director at Northwell. Like me, Mike has built a neurosurgery program from, like us, from the ground up. And someone who I always enjoy spending time with. And it is, as I said, my pleasure for him to be speaking to us today on metastatic tumor resection, bed radiosurgery indications and controversies. And with that, I'll turn it over to Michael.
Thanks, Ron. We certainly have seen a lot of water go over the dam over many years. And like you said, it's always a pleasure to get together and discuss and even ideally argue at times. And I'm glad that you were able to liberate yourself and get out of the New York area, even not geographically that far away, but of course, New York and Boston are like Athens and Sparta. So you really are in a different part of the world. So kudos for that and for what you've done at Beth Israel Deaconess and working with people like Chris Ogilvie by your side. What can you say? It's great. So this is really intended, especially for the residents going forward in your career, because treating, let's see, why am I not advancing? Oh, I got to do this thing. Oh, there we go. Why do brain metastases matter to neurosurgeons? They seem kind of humdrum as a problem. The surgery is not technically complicated. Yeah, you could do radiosurgery, but the fact is, this is a public health level issue. This is not an esoteric part of neurosurgery, an orphan condition where there are 400 people a year get it in the US. Not that that's not important, but this is the kind of thing that registers as a population health problem. There are about 40,000 people a year who get any kind of intracranial tumor, primary intracranial tumor, half of which are meningiomas in the country, and as many as 10 times as many of those get brain metastases. It's a third of everyone who develops cancer, and as people live longer with cancer, we're going to see those numbers increase. So when you look at what's happening with radiosurgery, which was initially invented by Lars Leksell in 1951, it's nothing new anymore. It's 71 years old now, and the Gamma knife is 54 years old. So it was initially invented to do functional neurosurgery, to create lesions in the thalamus and the basal ganglia, to treat pain, movement disorders, psychiatric disorders, and so on. But certainly once the Gamma knife came online, even pre-CT, it morphed into a way to treat morphological conditions, certain benign tumors that you could see pre-CT, like vestibular schwannomas and AVMs you could see on angiography. But over time, as you could see on this graph, which Electa provided, that has shifted more to treating patients with metastases. And this is worldwide. And if you look in North America, even more so, that's the green bar in the bar graph. Those are the majority of patients who get treated with a Gamma knife, and you can extrapolate from that for radiosurgery in general. So this is a very important part of neurosurgical practice, or, and I'm going to talk about this at the end, what should be neurosurgery practice. Remember, radiosurgery, stereotactic radiosurgery was a concept invented. It's a term coined by a neurosurgeon, Lars Leksell. All the improvements technologically that have been made in the decades since then have been by neurosurgeons. And we're beyond foolish if we kind of let that field, that treatment, so on, slip away from us for no reason. And again, look at the case mix by region around the world. In Japan, a leading country for stereotactic radiosurgery, country of about 130 million people, and the US, country of 330 million people, 2/3 to 3/4 of people who get Gamma knife radiosurgery are having it done for metastatic tumors. So if we go back historically, not all that long ago, until the late 80s, early 90s, if you had a brain metastasis, you might get whole brain radiation therapy, hang the crepe. Most people died within months. If you survived more than a year, you were lucky. So this began to change 32 years ago. Roy Patchell's a neuro-oncologist who was at the University of Kentucky at the time. And this was a relatively small volume randomized clinical trial. But this was the first demonstration that focal treatment for people of brain metastases increased overall survival and also decreased recurrence of the tumor. And this finally opened the door towards focal treatment for people with metastatic brain tumors. Now, in this time, every patient got whole brain radiation therapy. As that trial showed, they could have better survival if they had surgery in addition. But then in the aughts, people finally began to question if the side effects of whole brain radiation therapy really were worth it. So especially this study in the middle from MD Anderson, showed what was anecdotally obvious, namely that if you add whole brain radiation therapy to stereotactic radiosurgery, your rate of cognitive decline is much higher. And here they found at 6 months for it to be 52%. If you follow people over time after whole brain RT, it's going to be more than that. And in the ones whom you don't, to a WNL, it's like WNL means we never looked. It just means you're not testing the right things. Now, it is true that you will get more distant metastases if you do not give whole brain radiation and you only use a focal treatment like radiosurgery, but that just is because you're not treating that area. And of course, there's no obstacle to retreating someone who represents with a tumor. So whole brain radiation therapy still kind of remained a standard part of radiation oncology until this study came out 7 years ago. Now, it's interesting to see that they recruited 213 patients, but after a year, there were only 34 patients left to do the analysis on. Nonetheless, what these results showed was that survival and recurrence was no worse in the patients who had only stereotactic radiosurgery compared to SRS and whole brain radiation therapy, but their quality of life was much better. And this finally convinced the radiation oncologists, who are a very conservative group of people. You know, I'm not saying that's a bad thing. They're always saying, you know, we need the data and so on and so forth. So this gave them the data to support finally moving beyond whole brain radiation therapy as an automatic part of treatment for patients with brain metastases, even a single MET, you know, let alone more than that. So that was the conclusion of that study. So overall, the indications for SRS have not changed really in a couple of decades. The goal is safe and effective obliteration or prevention from growth. We prefer the lesions to be no more than 4 centimeters in diameter. Perhaps there's a little leeway with fractionation, as I'll get into a bit later on, but it's still true that the target should be as far as possible from such critical structures like the optic chiasm. To take an example, if you want to keep your chiasmal dose in a single fraction under 8, or if you want to push it a little bit 10 gray, you need 3 millimeters. And that's an important thing to keep in mind. Now, radiosurgery as a primary treatment can be highly efficacious. And here's a interesting anecdote for those who might be skeptical about that. This woman actually presented with signs with right hand numbness and clumsiness as her presenting a sign of her lung cancer. She had radiosurgery, 18 gray in a single fraction. Then she went on to have her lung tumor removed and was treated with chemotherapy. This is back in 2009. So this is pre the targeted and immune therapy era. She did develop what proved to be radiation necrosis. I said, gee, you know, we need to remove it, make sure it's not tumor. And she said, nah. She was a practicing physician, and on steroids, she was able to keep working. MR spectroscopy strongly suggested that it was radiation necrosis with a lipid peak there. And 13 years later, you can see the effects of the thoracotomy on her chest CT. The lesion has regressed to that little scar, and she's actually neurologically intact. So that's radiosurgery as a primary treatment. Now, I'm going to talk a little bit about medical treatment for patients with brain metastases. And as a neurosurgeon, if you're getting into doing this, you need to understand this. You need to know the concepts, you need to know the drugs, not as well as a medical oncologist, or for that matter, radiation oncologist, but you got to be able to talk the lingo to some extent. So this study showed that in patients who express EGFR on their non-small lung cancer, that Tarceva, not as a primary, but as a second line treatment, had a significant improvement in overall survival. Now, if we move ahead into the just a few years later, into the immune therapy era, this study showed that pembrolizumab, Keytruda, in patients who express PD-L1 in their melanomas could be treated with that alone and have regression of tumors without anything else, without any radiation. So you could look at this large right temporal tumor, and after the treatment with the pembrolizumab, yeah, could put us all out of business. But anyway, not quite yet, because you can see all the other tumors are, well, many of them are still there, and a couple actually grew a little bit. So there's, of course, still a role for radiosurgery, and the exact indication of when to use immune therapy alone as opposed to radiosurgery also, that's beyond the scope here. We don't need to get into that. But there are two basic pathways that have been elucidated for immune checkpoint inhibition in patients with cancer, the CTLA-4, the PD-1 or PD-L1 pathways. And ipilimumab was the first drug tried on patients with melanoma, which showed dramatic improvement in survival, even in patients with METs, including metastases to the brain. And this was a study looking at what about using the PD-1 or the PD-L1 pathway with nivolumab. This is Yervoy and this is Opdivo. Those are the brand names. And this study, in fact, showed that if you combine the two agents, that is, you use the CTLA-4 and the PD-L1 pathway checkpoint inhibition to treat patients with melanoma, that your overall survival is going to be better. Look at this, complete responses to visible tumors on imaging in 1 out of 9 patients. And if you add this, if you add these two complete and partial responses, these are documented responses, close to 3/5 of patients. So it's really impressive. If you think just 12 years ago or so, if you had melanoma metastatic to the brain, like you were a goner. Chemotherapy didn't work, didn't get into the blood-brain barrier. These tumors were resistant to whole brain radiation. And now we are fortunately in a whole new era of treating patients with, not just with melanoma, but a large variety of solid tumors that are metastatic around the body. This was another paper looking at combined Nivo and Ipi treatment as a standalone therapy for patients with brain metastases, again, showing over a 50% response with that alone. So you need to understand that when you're involved in the treatment of these patients. So like I said, if you go back 10 or 11 years, you have this whole kind of, not complicated, but somewhat elaborate, or you have a decision tree, what to do with somebody with brain metastases, resection, whole brain, you're talking about KPS, blah, 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 blah. But now, forget it, should say 2022. It's stereotactic radiosurgery, or maybe just immune therapy alone for some patients. So that is a completely different world that we're living in, which doesn't mean that surgery has no indications. A colleague of mine is doing resection of a brain metastasis today at North Shore. So if someone has a large tumor causing symptoms that need to be relieved and other considerations, you need to make a diagnosis, dealing with edema, if they have refractory seizures, if by some chance you're going to treat them less likely with gliadel wafers, certainly most unlikely nowadays, although it's possible, or with brachytherapy, and there are people still advocate for that. Those are good indications. And, as far as deciding whether there is a role for that versus things like, you're going to just do some form of radiation, yeah, you consider the patient's medical status, the morbidity of surgery related to the location of the tumor. Is it a radio-resistant or a radiosensitive tumor? Have they had other treatments, and so on. So now I'd like to talk about the controversies involved in treating patients, especially those who need surgery to remove a metastatic tumor, having laid the groundwork for radiosurgery overall in these patients. So Is postoperative radiosurgery even necessary after you've removed the tumor, especially with targeted and immune therapy? How is planning affected by the prior surgery? Do you just treat the cavity where you removed it? Is there a role for preoperative radiosurgery? Now, if you're not familiar with that literature, you're going to think that sounds crazy. That's what I thought. What about cystic tumors? Can you treat a cystic tumor with radiosurgery and kind of waste the radiation inside the whole volume of the lesion? And what about fractionation? It's the F word still for some neurosurgeons thinking about stereotactic radiosurgery. So what about postoperative radiosurgery? So this report in what the radiation oncologists call the Red Journal, or their Red Journal, demonstrated in a single center cohort that there was a benefit compared to historical control of adding postoperative radiosurgery after resection of a brain metastasis, that the likelihood of that tumor recurring was much less. More recently, this was a randomized controlled trial, which showed that the rate of local recurrence was greatly reduced in the radiosurgery arm. Now, this may seem to you as proving the obvious, but nonetheless, it's good to have this sort of thing proven with data so that we know. Okay, so what about postoperative whole brain radiation? This is a paper from only 5 years ago. So this is, again, still a topic that was kind of only put to rest relatively recently. And what this showed was that the likelihood of neuropsychological deterioration was much higher in the, by the way, can you see my cursor? Anyway, it's on the right here, especially the upper right. Much higher in the patients who got whole brain. Was that?
We see it. Yes, we see it.
So it's much higher in the group of patients who got whole brain radiation therapy. And that should not be surprising. And you could see it here in this curve that the avoidance of cognitive deterioration was unsurprisingly much higher. It was much lower in the radiosurgery group. Again, confirming the obvious, but we can now say that we have data for that. So anecdote, and you may all be familiar with this, postoperative radiosurgery in somebody who unfortunately was thought to have a curative resection of a melanoma, but then 3 years later presented with a symptomatic metastasis. And then she had planned cyberknife radiosurgery and a single fraction. A month later, we were actually installing our gamma knife at that point. So we had in our system at the time an affiliated cyberknife. So we treated her there, we gave her 20 gray, and then she actually had a new parietal tumor a few months later, which we treated at this point with the gamma knife. And you might think, well, that's not going to go well for her if she's sort of sprouting new tumors. But then she was treated with ipilimumab. Again, the brand name is Yervoy, and here we go, 8.5 years later, after a year of ipilimumab, she has no evidence of disease anywhere in her body 8.5 years later. Really remarkable. And this is just a scar here after the surgery in the SRS, and the perfusion MRI over here shows that it's cold. Okay, so we know that radiosurgery is a good treatment for patients with brain metastases, and without a doubt, postoperative SRS, forget whole brain RT, postoperative SRS is desirable and I would say necessary. Now, how does prior surgery affect planning? What do we just try to treat the cavity? So this paper from University of Pittsburgh kind of surprisingly showed that if you add a small margin to your resection cavity after resection of a brain metastasis, rather than being completely conformal, that you have much better local tumor controls. Because this is from a group that was preaching for 20 years the benefit of conformality and it's best done with the gamma knife and so on. But no, not when you're treating someone with metastatic cancer. There you want to make sure you're sterilizing the whole cavity by adding a small margin around that. And this was reinforced by this paper from Stanford using the CyberKnife, where again, they show that adding a 2 mm margin to the resection cavity had a dramatic effect, improving local control after prior resection of a metastatic tumor. And it was in a way almost kind of linear. As you got less conformal, you had better local control, reaching 100% with the least conformal plan. So, you know, pretty good on the Kaplan-Meier curve here. This was a consensus paper asking experts in radiosurgery to look at cases and to draw plans and to derive some sort of guideline, if you will, from that, but not a scientific study in any way. And you could see that basically the consensus here from everyone, and it did include a couple of neurosurgeons. You've got Veronica Chang, Lily Angelov, and Jason Sheehan. Everyone else here is a radiation oncologist. So everyone included the dura outside of the resection. They did not limit it to just the treatment plan. This stacks the deck a little bit because, as you can see, all the tumors in these examples are superficial. What do you do if your patient doesn't really fit what was presented in those guidelines? So this was a young woman with non-small cell lung cancer. She did express PD-L1. So in addition to chemotherapy, she was treated with pembrolizumab, but she had side effects that caused her to stop the treatment. And she had a systemic response, but then she developed this metastatic tumor, which was symptomatic. And because of the size and the edema, the medical oncologist thought, and I agreed, that she was best off having it resected. So now what do you do? How do you treat her radiosurgery? So based on our experience and those guidelines and common sense, we treated the whole tract. So even though this tumor was deep and the resection cavity was deep, we didn't just put a margin around it. We carried it all the way out to the dura, which ends up with a larger treatment field. And that is why we fractionated her treatment and treated incidentally this other tumor with a single fraction. But there she is. She's back on her pembrolizumab and she resumed intactness, and she also has no evidence of disease a few years later. Okay, radiosurgery is good for patients with brain metastasis. Postoperative radiosurgery is necessary. You need to be a little generous when you treat those patients with your margin, as opposed to being purely conformal, like we want to be for people with benign tumors, let's say, where we're worried about putting radiation to the normal brain. It's a little different here. But what about this idea of preoperative radiosurgery? It sounds kind of nuts. So this was a multi-center study. This idea was first propounded by Tony Asher, who's a neurosurgeon at the Carolinas Institute and president-elect of the AANS. And his idea here was that by doing preoperative radiosurgery, you will decrease probably the worst complication of surgical resection of metastatic tumors, namely leptomeningeal disease. When that happens to somebody, it's a tough situation. There's not that much to offer except whole brain radiation, which we're been trying for 30 years to avoid doing. So what this study in fact showed, following up on single center retrospective data from Carolinas Institute, from Tony's work, was that the rate of leptomeningeal disease, or of symptomatic radiation necrosis, was also greatly diminished in the patients with preoperative radiosurgery. But I think more importantly, the likelihood of leptomeningeal disease was also really greatly diminished. So this is a strategy that we have tried to incorporate. We're a little bit hamstrung in our institution because our whole radiation oncology gamma knife center is outpatient. So patients who come in to the hospital with a large metastatic symptomatic tumor can't be discharged for gamma knife and then brought back in. So otherwise, this would be a strategy we would employ much more often. And I would certainly encourage everyone to consider it, to strongly consider doing it. This was somebody who had a metastatic lung cancer, who had been treated with targeted therapy with durvalumab and with chemotherapy, but then he had this symptomatic cerebellar tumor. So we treated him the day before surgery, and you do surgery the day after SRS in these people. You could see the changes in the tumor. Their tumors are grayer, they're less bloody, they're somewhat firmer, they're a little more adherent to the surrounding brain, but not a big deal. It's not a technical challenge to remove them. So now he's on Keytruda, and he was doing well on that couple of years after surgery when I last saw him. So to recap, radiosurgery is good for patients with brain metastases. You have to do postoperative radiosurgery, and you have to add a margin to avoid local recurrence, and strongly consider in patients in whom it's possible doing preoperative radiosurgery, as long as you operate on them basically right away within a day or days after the SRS. What do you do though with somebody with a cystic metastasis? Do you have to resect those? Can you just treat them with SRS? The problem with the latter idea is that tumors are often big, and what's inside the cyst is not going to respond to radiosurgery, just a bunch of, dead cells and other debris that's floating around. So you're treating this large volume, putting the surrounding brain at risk. And you're probably not preventing the cyst from growing anyway. So this paper from South Korea showed how you can aspirate the cyst and then do SRS right away. The problem with that is that what do you do when the cyst recurs? You have to take them back to the OR and then re-aspirate it. So here's a simple idea. Put in a reservoir, and then you can aspirate it as an outpatient without difficulty. This is a patient whom we did that, but actually he didn't end up needing any further aspiration after the original aspiration in the OR and the radiosurgery. And 18 months after the SRS on chemo and pembrolizumab, he was asymptomatic and had complete control of his systemic disease. Here's a patient who did need additional aspiration. She was 80 years old, and she had systemic mets in addition to her symptomatic left temporal tumor that she developed when she stopped her immune therapy. She did that because it wiped out her pancreas, and she got type 1 diabetes. I don't know why they stopped the ipilimumab then, because the damage was done. Anyway, that's what she came in with. So to try to do the least invasive and smallest surgery possible, I put a reservoir attached to a catheter attached to a reservoir into the cyst, aspirated it. Now, when she came back for her radiosurgery, MRI showed that the cyst recurred. So we chose to treat the whole cyst, and then I aspirated it afterwards, and her language came back to normal. And I did have to aspirate her twice more, and she did die of her systemic disease 8 months later, but she was able to get control of her large brain metastasis with this relatively simple approach. So here's a small series, or you can call it an expanded case report, that recently was in Neurosurgery Open. That's one of the kind of loser journals where if you don't get into the main journal, they say, we could publish it here, but it's going to cost you. And anyway, don't do it. I'm not doing it again. But anyway, it does. It did appear in a journal, and again, this is what we saw over time. That, of course, the cyst volumes decrease initially after you aspirate them, and then they enlarge when the patients come for radiosurgery. But after SRS, they go down if you redrain them, and they stay down. And that's the benefit of putting in the reservoir, not just doing a one-time aspiration. Okay, so to recap, radiosurgery is good for patients with brain metastasis, you have to do it post-op. You have to add a margin, including the tract, if necessary, after surgery. Strongly consider doing preoperative radiosurgery to decrease the risk of leptomeningeal disease and symptomatic radiation necrosis. If you have a cystic metastasis, you don't have to remove it surgically. You can drain it, leave it in a reservoir, do radiosurgery to what's left. Now, we're going to start to merge into what will be a little bit polemic territory, as you'll see. What about fractionated radiosurgery? You know, we think intuitively, well, you know, the more you get to a single dose, that's how Lexell conceived of it. You come in, you have a single treatment, you go out, what the Pittsburgh group calls wheels in to wheels out. It's kind of more neurosurgical. And anyway, it's going to work best if you do it in a single fraction, right? Well, probably not for patients who have metastatic tumors. Somewhat counterintuitively, this study from South Korea showed that the patients who were treated with hypofractionation had better local control than those who had a single fraction. That has to do most likely with a different radiobiology of a malignant versus a benign tumor, or for that matter, a benign lesion, including AVM, related to the rapidity of cell turnover and so on. In our own retrospective and yet unpublished study with LINAC radiosurgery, we found a similar result. And it surprised me and my colleague to a large extent. That's one reason we didn't publish it earlier, trying to work on it now and add some gamma knife data. So we didn't believe it. Like, how could it be that the patients with fractionation did so much better in terms of local control? Anyway, here's an example of how it works. This woman has had a long history of breast cancer, came in with this large symptomatic tumor, and the assumption was she was going to need surgery, but it's straddling the sensory motor cortex. And I said, you know, we're not going to make her better if we take it out. Let's treat her with fractionated radiosurgery. And you can see the imagingly, the result is terrific 8 months later. And in fact, she recovered all of her symptoms. She, you know, recovered her gait and lost her hemiparesis and so on. And that's with a 3-fraction treatment for a large tumor in a so-called eloquent area. And this is true also for people who get preoperative radiosurgery. So the reason to fractionate this person was that she was symptomatic. She had at least partial left hemianopsia. So we treated her over several days, beginning 5 days before the planned resection. We still gave her a pretty healthy dose for someone with non-small cell lung cancer, a total of 24 gray. And you see the same thing as you do after single fraction radiosurgery, avascular, somewhat firm tumor that is not difficult to remove. So how do you do fractionated radiosurgery? Of course, then you're talking about doing SRS without a stereotactic frame. Now, neurosurgeons may have to be dragged kicking and screaming into doing that, because gamma knife with a frame, you know, we've been doing that for 54 years. All of stereotactic surgery involved frames until the last decade, pretty much. It's got proven accuracy, again, wheels in to wheels out, but you can only, practically speaking, do single fraction treatment. And patients may not like it. And you have to accept the fact that ever since focal radiation in what became radiosurgery was being done, radiation oncologists and neurosurgeons have been trying to get away from doing it with a stereotactic frame. So here's an early example of doing it from Sweden with a linear accelerator. The Leighton stereo adapter was invented by Laurie Leighton, a really pioneering, well-known Finnish neurosurgeon who worked in Sweden in the 60s through the 80s. And this stereo adapter, as it was called, which looks somewhat makeshift, but was used for many indications, including radiofrequency lesioning, let alone stereotactic biopsy and so on, was adapted for radiosurgery use. And Dr. Alterman at least might be amused to see Marwan Hariz is the first author on this paper. Certainly not the typical lane for Dr. Hariz to work in. But again, the point is you could do radiosurgery without an invasive stereotactic frame. Now, around the same time, these sort of exotic ways of trying to do it, this is from the University of Miami, by attaching a halo. Look, we used to put on lots of halos for people with C-spine fractures. Why not do it so you could do fractionated radiosurgery over even a couple of months? And here you look, you got a smiling patient. But let's be real, this is not a practical solution for most people. This was the first thing that was kind of practical for use. Now the neurosurgeons get to implant the bolts to which the Talon device would be attached. But again, do you really need to do this and send somebody home with the antenna sticking out of their head? And it's not like there are no risks of infection with that. And no, not practical. But this, what came to be known as the Gill-Thomas-Cosman frame, was a practical solution. And you could see what Gill and Thomas, who are neurosurgeons in England, showed was that the accuracy of the frame aimed at a single target was pretty darn good, you know, and comparable to what you get with a stereotactic frame. Now, this doesn't mean that it immobilizes people as well as you need to for radiosurgery, but for fractionated treatment of a large target, certainly was possible. But John Adler, he's the guy who let the genie out of the bottle. So John was a neurosurgery resident at the Brigham, and he did a year fellowship with Lexell while he was a resident. And he thought radiosurgery with a gamma knife was like the coolest thing ever, but it was limited to the head. How can you take it into anywhere in the body? Well, you have to liberate the concept and the patients from the stereotactic frame. That's what led to his developing, really imagining, and then bringing it into reality, the CyberKnife, which uses a mask to treat people in the head, but could treat people anywhere in the body, spine, but not just the spine, certainly used by a center not far from where I am in Long Island to treat, you know, many people. So it's the leading CyberKnife center for treating people with prostate cancer. For those who don't know, it uses flat plate x-rays registered to pre-treatment CT and a robotic arm to account for any small movement of the patient during treatment. And this really opened the door towards hypofractionated radiosurgery. And the CyberKnife is a form of linear accelerator radiosurgery. So this survey done by people at Yale showed how the use of LINAC radiosurgery was increasing compared to gamma knife radiosurgery around the country. And this tends to be driven by far much more by radiation oncologists and not neurosurgeons, both in academic and non-academic centers. So what the gamma knife icon, which was introduced 4 years ago, did was it kind of ended the era of frame-based radiosurgery. It put the final nail in that coffin, because with the icon, you can track people with a mask, make sure that that your target is still where it needs to be in the isocenter of the gamma knife, and also compensate for small movements that occur while you're doing the treatment. So we started doing this 4 years ago, and I was curious to see how patients would react to it, because you might think it's obvious that they prefer to not do the frame, but for me it wasn't, because the mask is really tight in your face. And when I was trying out a system once at the University of Florida, I saw how tight that thing could be. And compared to the pain involved in putting on a stereotactic frame, you know, once the frame is off, or once the frame is on, it's on. And then there's no more pain. But the mask, you got to have on the whole time. So we gave these questionnaires to people to fill out after their treatment. And this is me putting on a BRW or CRW base ring. And Bob Heery, who was a resident at New Jersey Medical School, or as at the time, and took the picture, said the caption should be, "The procedure is well tolerated." Anyways, you can see the patient is not very happy there. So somewhat to my surprise, our patient survey showed that people dramatically preferred the mask to the frame. They found it less painful. They found it less uncomfortable. And this was independent of diagnosis. I thought that people with benign tumors who are getting a curative treatment rather than those with malignant tumors who are just seeing this as part of a whole, round of torture would tolerate the frame better, but that did not prove to be the case. So the mask wins out. Now, the fact is you can mimic the wheels in to wheels out workflow with a mask. You can image them, cure the mask that molts their face, plan the treatment and treat them on a same day, similar to what's done with a stereotactic frame. And this study from the University of Buffalo, Dhirendra Prasad, is well known as a radiation oncologist who does and advocates for stereotactic radiosurgery. And they found that this was a reasonable way to treat patients, to do it on a single day. Now, we were curious to see what the effect on treatment would, done the same day, would have. And we found that the treatment time was basically the same. It was a little bit less in the same day patient group, but not much. This is what a printout looks like from a patient who's treated while they're getting treated with a mask-based Gamma knife, or the Icon, which is the brand name. As each X-ray image is shot, we're looking to see, or rather, as they're tracked, we're looking to see if they move. And if they move more than whatever your tolerance is, typically a millimeter and a half, the treatment is stopped. The on-board cone beam CT is repeated. And once the registration is redone, the treatment is resumed. So we found that there was no significant difference in the, statistically significant difference in the treatment time, but the pauses were greater in the patients who were treated the same day. And the question is the mask less rigid if it's made on the day of the treatment? And is it better off being done in advance and not trying to mimic that neurosurgical wheels in to wheels out treatment? And that's something that we're continuing to look at over time. So you all, and especially residents, will say, well, gee, you're using a mask and they're getting treated more than one day. That's not neurosurgery. That's not even radiosurgery. Well, is that a fact? This was a paper published in the Journal of Neurosurgery, and at the same time in the International Journal of Radiation Oncology, Biology, and Physics. That's the official journal of ASTRO, the American Society for Therapeutic Radiation Oncology. This was an officially agreed upon definition of radiosurgery by organized neurosurgery and radiation oncology. And this is what it said. These are quotes from the paper. And it can be performed up to a maximum of 5 treatments. So if you're doing 3 treatments or 2 or 5, that is stereotactic radiosurgery. And we must insist on that language and not let it get called stereotactic body RT or stereotactic RT, none of that. It's SRS. And again, from the paper, you could do this with a LINAC, with heavy particles, or with multi-source cobalt-60 units. That's Gamma knife, okay? So you could do it up to 5 treatments, and it's radiosurgery. So the challenge is, how do neurosurgeons stay involved in this? How do the next generation, that means you residents, take this seriously and not basically let this very important clinical, and put it right on the table, part of practice and financial part of neurosurgery, not slip away from us. We need to maintain a collaborative, multidisciplinary approach with the radiation oncologists. And there were 2 studies 4 years ago that showed that even though residents were planning and wanted to do radiosurgery in their careers, that they did not perceive that their training in residency was adequate. And the faculty kind of felt that way as well. This is another study that kind of showed the same. Half of residents are uncomfortable doing intracranial radiosurgery. I mean, it doesn't take long. I put a lot of time into it myself, but it does not take long to really understand how to do it. So you guys gotta, take this seriously as residents and afterwards, and make this a part of your careers, because look what's going on around the country. In academic centers, a sixth of patients are having radiosurgery without any neurosurgical involvement. And in non-academic centers, it's a quarter of the treatments, and only selected in 43%, selected in 28% of academic centers. So that means over 2/5 of the SRS patients in academic centers could be done without a neurosurgeon involved. So on the clinico-scientific side, yes, after you resect the brain metastasis, you need to do radiosurgery to prevent local recurrence. And you need to add a margin to confirm there won't be local recurrence. You should consider preoperative radiosurgery and consider this strategy to treat people with cystic tumors, leaving a reservoir. But fractionated radiosurgery for large tumors is here to stay, no matter what your platform is, and it's a neurosurgical treatment. It's stereotactic radiosurgery, whether you're doing it with 1, 2, 3, 4, 5 sessions, and you need to be involved in doing it. So guys, neurosurgeons need to be involved in radiosurgery. It's the best practice for the patients who are going to be living longer with metastases. This is going to become even more so the dominant indication for stereotactic radiosurgery, and it behooves us to keep doing it and not just have it done by radiation oncologists. So I hope you listened, and if you did, thank you for doing so.
Michael, that was a great run through. In a lot of centers, it's how are these centers setting up that the treatments are done without neurosurgery? Because in a lot of centers, it's almost a mandate that neurosurgery be involved. Is that just getting away from that, or I know usually it's the institution, I think, but I think that it's there's no rules on it, I guess. How do you get around that?
The authorized users of therapeutic radiation it's state by state, but I'm quite sure it's every state in the country. The AUs are the radiation oncologists. They're the ones who have to push the button and be within shouting distance. Actually, literally, they got to be within verbal distance of the radiation therapist who's handling the machine while the treatment's going on. The neurosurgeons don't have to be. The AMA, the insurers don't require neurosurgical involvement. Now, most places, and I'm lucky to say that it's true, with us here, have a good relationship with the radiation oncologists, and they want you to be involved. But to the extent that you sort of, you as a neurosurgeon, withdraws and doesn't show up and kind of says, well, send me the PDF, and then you get it on your phone or or an email and say, yeah, looks good. For a while, the rad oncs may say, okay, we're doing this together, but after a while, they're going to get the hint that you're not really involved with them. And you need to have a physical presence, and to the extent that you're looking at things remotely, when it's appropriate, you got to say there's too much dose there, or is that dose? Yeah, I get it. We're giving him 24 gray, but maybe we should give him 27 gray in 3 fractions. Or, I don't like the fact that the optic chiasm is getting, that much dose. We got to, you have to be involved that way at a minimum. There was a requirement for fractionated radiosurgery that the neurosurgeon be present for at least one treatment to bill. But then I went back this year and looked at it, and that language is removed from the vignette by the RUC, the Reimbursement Update Committee. I looked everywhere I could in insurers' documents. So it's all ambiguous. So it's not a requirement, but again, the less interest that I'll say we now as neurosurgeons show in this, and the more we take our involvement for granted, the more likely it is going to slowly, slip away. And that would just be a terrible mistake.
Yeah, I'm Michael, it's Phil Towski here.
Hi.
I really enjoyed your talk and your emphasis on that this is a neurosurgical specialty and neurosurgical discipline. And just a few anecdotes around that. You know, the residents, sometimes it's so important to understand the history of this. So Yazergil actually bought a gamma knife with his own money because he realized how important it was. And the University of Zurich didn't allow him to install it and use it because they were afraid of him getting actually too powerful. But
Can't let the Turk get too powerful.
yeah,
That's an amazing anecdote, really.
so this was always a neurosurgical discipline. And then, you know, the residents, sometimes they feel that stereotactic radiosurgery, it's not surgically very challenging, but I reviewed a paper recently on Ladislav Steiner, you know, the great pioneer who came to UVA. He actually clipped over 2,000 aneurysms. So it was really seen as part of neurosurgery. The people who did it were neurosurgeons. They integrated it in their open surgical practice. And I think it's the same with endovascular, right? We see endovascular as a radiological discipline where in fact it has always been neurosurgery. You know, Al Roten at Mayo, when he started out, his main business was doing angiograms. And the main textbook on angiograms is written by Yazergil, who did all the angiograms himself. So I think an amazing push on your side, and I completely agree. This is a neurosurgical discipline, and I say that with a brother who's a radiation oncologist, but it is neurosurgery. Stereotactic radiosurgery is neurosurgery.
Yeah, and the fact is, in Europe and in Japan, the neurosurgeons can do gamma knife without a radiation oncologist.
That's correct.
But that is not true in the US and in I don't think it's true in the UK and other parts of the world. But be that as it may, as things move away from that neurosurgical idea of, you know, again, you put on the frame, you image, you plan, you treat, you take off the frame. As it moves towards a radiation oncology type workflow with a mask, even in Western Europe and in Japan, it's going to also morph into radiation oncology. And look, we invented it. Lexell was a neurosurgeon, for those who don't know. You know, used the Rondura in the OR every day. John Adler invented the cyber knife, neurosurgeon. Mark Carroll, neurosurgeon at Pittsburgh. He invented a different system for fractionated stereotactic radiosurgery in the 90s. Alan Hamilton, the first person to demonstrate spinal radiosurgery, neurosurgeon, a contemporary of Dr. Ogilvy's at Mass General, although he did that work at University of Arizona. So that's all neurosurgeons who did that. So why should we have done that and say, hey, radiation oncologist, here's something on a silver platter we're handing over to you? There's no reason. We must evolve as technology evolves and apply the best treatment for the patients. And don't worry, residents, you could do endovascular, there'll be plenty of open vascular surgery to do. You could do radiosurgery, there's going to be plenty of open tumor surgery to do. It's all part of making things better and having better outcomes.
All right. Any questions from the residents?
Hi, Dr. Schulder. This is
Hey, how you doing?
Hey, I'm good. We met many years ago in New York.
Are you a chief resident yet?
Yes, I am chief resident yet.
Wow.
That's true.
That's great.
Thank you. Good to see you. I just want to ask, what's your approach about SRS for posterior fossa lesions? Are you a little bit, are you just more conservative? Do you have like different cutoffs? What's your approach? You use fractionation more?
You know what? I should have put that in the talk. Just as it is, you know, I kind of just got in under the wire time-wise. Until like a year and a half ago, I thought if you have what looks like a large post-fossa metastasis, you absolutely have to take it out because they could get hydrocephalus and brainstem compression. That's not true. There was a paper from the Cleveland Clinic that was in JNS. It was actually a cover of the journal a year and a half ago. and it pretty definitively granted retrospective review, but they had like 70 patients, not 8. It showed that you could treat those patients with either single or fractionated radiosurgery, and none of them had significant brainstem compression. They all had local control, and none of them needed a shunt. Actually, one patient or 2 patients did, but not because of fourth ventricular compression. One might have had leptomeningeal disease, and the other had some other reason for the shunt. So that's it. So we changed our practice here. That to me was like a 180-degree change. Now, if one of my colleagues here is on call and someone comes in and they still take out a post-fossa met, it does raise my blood pressure, because it doesn't happen that often, but most of the time when it does, it didn't have to be. They could have been treated with SRS only. And that should be what we all do going forward. Yeah, that's a paper that you should look at. It's really quite impressive.
Hey, this is Dr. Vega. Usually I do a lot of the brain tumor surgery here with respect to, like, some radiosurgery to follow, right? And one thing about these posterior fossa cases I want to mention is I like your approach, and I do such a thing as well sometimes, but I wonder if there's some specific, cutoffs. I've had 2 patients where I did try to do stereotactic radiosurgery, and they came back with significant edema, now they're vomiting, nausea, and I'm worried about, whatever, so we got to do it. But I'm curious if there's any kind of cutoffs you found, right?
A, no. B, there'll never be a hard and fast answer to that. C, you did them a favor because you did preoperative radiosurgery on them. In fact, post-fossa mets are the ones where you have to worry the most about leptomeningeal disease. And if they're large and you're taking them out in piecemeal, which you kind of have to do, at MD Anderson, this is a while ago now. This might even be like 2009. They, believe it or not, they did a prospective study that showed that if you take out post-fossa mets piecemeal, you're much more likely to get leptomeningeal disease, which is, makes common sense, but you think, why would you study that? But anyway, they did, but by doing the SRS, even if it's a week or 2 in advance, even if you plan for it to be a definitive treatment, you have greatly reduced their risk of leptomeningeal disease. So, Raphael, it's like pornography, the Potter Stewart definition, when you see it. If they've already got obstructive hydrocephalus, are you going to put in an EVD and then treat them with SRS? No, you put an EVD and take out the tumor. Right. Or if their fourth ventricle is a sliver and they're already vomiting and they're ataxic all over the place, and yeah, you're going to take that out. So I don't need to tell you that.
Thank you. One other thing I wanted to ask is about this preoperative, stereotactic radiosurgery. I found that very fascinating. I've seen there's something called the STEP study that's like trying to evaluate this, right, in a prospective way. And I guess they're talking about reducing the risk of radiation necrosis as well, right? I don't know. Here, we don't have Gamma Knife, right? That's at Tufts, but we use the CyberKnife system. And for most of our cases, we have to do some, fractionated work. And I'm just trying to think, like, if you do preoperative and you say you take it out the next day, but let's say you have 5 fractions, is that something that I guess you can potentially do?
Totally.
Yeah.
First of all, you could do a single fraction with a CyberKnife, but you also do 3 fractions. And if your CyberKnife is in the hospital, so you could do the inpatients, you should do it totally.
Okay.
The only thing the way Tony Asher described it is using a lower dose. That because you take it out the next day, you can use a lower dose, and that reduces the radiation necrosis. Our standard dose, we don't follow that RTOG guideline. We give them 20 gray pretty much all the time. Maybe you reduce it if it's super eloquent, but then we're probably not taking it out. So we give them 20 gray, and in our small, how many patients have we done? Like 12 this way. We haven't had any recurrences. There was another study that looked at the results, and they found that the local control was worse with a preoperative SRS, but that's because they were using those lower doses. So you can use a standard dose if you're going to do the strategy.
Well, thank you again for that talk. I mean, it was really, really good.
Thanks for listening.
All right. Well, Michael, thank you so much. Great seeing you as always.
Yeah,
And hope to see you soon.
yeah, come to something.
Yes. No,
Not
I
the meetings we talked about, but yeah. All right.
Yeah. Next year in Brooklyn.
Amen.